Achieving a balanced lifestyle doesn't have to be a dream, and wellness doesn't have to be an activity you save for downtime. Instead, elevate your personal and professional life with the tips, tools, and insight to holistically support healthier habits. Join me, Dr. Callie Davis, in the Mind-Body Connection for enlightening conversations, inquisitive panel discussions, and illuminating stories from experts in the medical and healing communities who are leading the movement toward a holistic approach to health. Today we have a very special guest, Dr. Ryan Krlin. He is top-notch in his field of urology, and he's an amazing surgeon. I'm so glad we get to unpack these really juicy topics with you today. Dr. Ryan and I happened to meet each other recently in New Orleans in a very New Orleans type of way at Jazz Fest. We were having a good old time, soaking in the vibes of the music, and as things would go, we ventured off into talking about pelvic floors. And we discovered that we both work in this territory with people to help them improve their lives. So we said, why don't we do a podcast together? And today we're going to dive deeper into that subject matter. So I'm very happy to have you here with us. Thank you, Dr. Ryan.
My pleasure.
Let me give a little bit of background to our listeners on your training because it's quite extensive. So a native of Oklahoma, he graduated with honors from Oklahoma State University with degrees in Biochemistry and Spanish. He then earned his medical degree at the University of Oklahoma College of Medicine in Oklahoma City, finishing in the top quarter of his class. Following graduation in 2005, that must have been right after Katrina, huh?
It was.
Wow. So you decided to move to New Orleans then?
Something like that.
Wow. That's pretty remarkable right there. And then you completed a urology residency in the LSU-Ochsner clinic program. And then 2 years of subspecialty training in female pelvic medicine and reconstructive surgery in an ABOG accredited fellowship at the Glickman Urological and Kidney Institute of the Cleveland Clinic in Cleveland, Ohio. He is not messing around. He returned to LSU to join the faculty as an Assistant Professor of Urology and Gynecology, teaching medical students, residents, and fellows, and he now serves as an Assistant Program Director for the LSU FPMRS Fellowship and the LSU Urology Residency. So I will hand it over to you at this point, Dr. Ryan, to explain a little bit more about your current practice, the things that you really love to do now in your field.
Yeah, so I would say probably 95% of the practice now is dedicated to female urology. I see a little bit of male voiding dysfunction, male neurologic or neurourological issues. As far as surgical, it mirrors that. I do some surgical intervention for male voiding dysfunction, but the bulk of my practice is directed at the female patient population.
Awesome. And that's definitely where we can connect on some of our experience and our background in the clinic. I love being able to treat female pelvic dysfunction too, as a manual physical therapist. And I generally find that when we are sitting in the room with pelvic floor PTs, there's a lot of, now thankfully, there's a lot of highly specialized pelvic floor PTs around. We don't have a whole lot of them in New Orleans locally. We have a cluster, but we have enough going on in our field now to draw from a good wide array of evidence to back up our treatment methodology. But sometimes I feel what is missing from the pelvic floor PT specialty field is that overall body approach. Like, what is actually going on in the spine? What's happening in the hips? What's happening in the foot and ankle when this patient walks and bends and squats and does all their functional motion? So when I started to study pelvic floor specialty, I was coming at that from a very orthopedic and manual therapy mindset of treating the spine and the shoulders and hips and everything else, and then diving deeper into pelvic floor. So I look at it a little bit differently. I still see it as like a whole part of the whole body. And I definitely love working with patients who have had chronic stress or a background of trauma that has been interfering with their ability to make progress and gains. So where they're just kind of stuck and looking for solutions. So you are treating in your caseload a good amount of patients who've had sexual pain.
Mm-hmm.
Yeah. Does it vary from like what's causing it? Like, do they have all kinds of different wide varied issues going on, or do you see kind of like a narrow spectrum of those cases?
Well, that's an interesting way to phrase that. But, what I find many times is that and the analogy I use with my patients is that it tends to be like a snowball type effect, right?
Yes.
So there was an initial insult, be it sexual, be it some other mechanical modality that caused some level of pain. Mm-hmm. And then as that continues, whether it was an unfavorable sexual experience, and then when continued without resolution, it just compounds, and every time is worse than the time before, until a lot of my patients may end up with complete vaginismus, right? Like where they are even willing to accept penetration at all. And it's involuntary, right? I mean,
Right.
you're aware of vaginismus. Like it's just a body response that is, and that happens.
Yes.
Yeah.
And it's like those patients experience like a blockade with it.
Correct.
They're like, where do I go? I'm hitting a wall.
Right.
I've seen this provider, I've seen this. Now that we have so much of an explosion of wellness practitioners too, I feel like there's a lot of reaching out in like, I've done acupuncture. I've done like this retreat in India. I've done, they really go the distance to try to get past that wall.
And, oftentimes it just starts with very, very basic, or the way I approach it is, okay, you're not even at the point right now that physical therapy is even an option.
Right.
So in my practice, I will start with, topicals, or I utilize my pharmacology friends in
Mm-hmm.
compounding pharmacies and using compounded vaginal suppositories. Like, let's start there. If you can get some initial relief, then maybe we can get to the point where you can start to tolerate some physical therapy. And again, I am a big believer in physical therapy because, and I tell patients this, like, listen, this didn't happen in overnight. It's not going to go away overnight. This is going to be a chronic thing, and even when we get to resolution, it's still going to require maintenance.
Yes.
But some of those patients, you have to just start with, I'll start with the pharmacologics, if that gives them a little bit of relief, then they can start some easy, and then this is your department, physical, pelvic fluid directed physical therapy. And oftentimes, if it gets severe enough, I'll even augment it with like Botox to the pelvic floor muscles so they can make additional progress. But yeah, it become a big deal.
Totally. And okay, let me back up for a second. With the pharmacological approach, I know it seems like maybe in the past 3 to 5 years, I guess, it's been, or maybe longer than that, we've been seeing a lot more success with estrogen-based suppositories, right? And
Sure.
creams.
Sure. I mean, for atrophy, for postmenopausal atrophic vaginitis,
A
absolutely.
lot of issues, right?
But we're even seeing more of its utility even in premenopausal females.
Right.
That there's some level of, I don't know if it's estrogen insensitivity or but maybe the increased levels of a topical estrogen cream can be beneficial even in premenopausal females.
Yes, and that's definitely like gray area, kind of murky area to try to figure out for all of us, like in interdisciplinary work. We're like, we don't have enough research and data to go off of to be able to sometimes crack the code with the premenopausal
Yeah, that's true.
patient cases.
But at the same time, we also know from the studies that have been done that topical vaginal estrogen creams yield very minimal systemic absorption when measured, that I don't think using them vaginally is really going to like push the circulating estrogen levels, to a super therapeutic level, as the effects of it stay localized to the vaginal tissue.
Got it.
Yeah.
So in vaginismus, in that case, then you would see maybe a better change towards baseline function.
Well, yeah, I mean, I don't, and again, using topical estrogens for vaginismus, I don't know how much that's going to help, that issue. Sorry, maybe I didn't make myself clear when I was talking about pharmacologics. I will use a combination of lidocaine, Valium, and baclofen in a compounded form for muscle relaxation, relief of pain, and that is what I will prescribe my patients prior to physical therapy, or as a segue to physical therapy if it's to that point.
Okay, got it.
Yeah,
So,
estrogen. Yes, yes, across the board, I'm on board with vaginal estrogen, and the whole discussion we had of premenopausal, postmenopausal, yes. But in respect to that, I was talking about the baclofen, Valium, and some lidocaine. And that can really help patients make a lot of progress with physical therapy.
Wonderful. So then what you're approaching there is really more of the modulating pain.
Correct.
Getting to, that central nervous system response to pain, where we know, like, if there is pain signal coming in, there is going to be tension in that response.
Right.
And the muscle tissues are, like you're saying, you might see a very severe case where we all would like to, as practitioners, go, what can we do to this feedback cycle to unlock that?
Right. Mm-hmm. It kind of feeds into the whole concept of the pelvic organ crosstalk theory, right? Where, like, we entered this with pelvic trauma, sexual trauma, but even like a rip-roaring UTI with really, really bad dysuria, where they have that really severe urethral pain, can be enough to trigger that upregulation of nerve endings. That then the next thing you know, they have vestibulitis, and then vestibulitis, leads to introital pain during intercourse, and then full-on pelvic floor muscle tension, and then
compounding.
Pelvic floor muscle dysfunction. Yeah.
Definitely the snowball effect there that you just described.
Yep.
And you see a lot of these cases that are the snowball effect.
Yep, a lot.
And how many of them are coming into your clinic and saying, well, I've been doing Kegels like everybody told me to do.
Yeah.
Do you say Kegel or Kegel?
No, tomato. Yes, and I agree with you. And I see these patients, and I was like, yes, hold on, slow your roll. Mm-hmm. We can exercise these muscles differently. We're not trying to create tension in these muscles. And that's one of the really interesting things. And I find it really unfortunate that a lot of generalists, both urologists and gynecologists, completely overlook it. But, when they say this patient has no pelvic floor muscle tone, well, of course they don't, because they have a spastic pelvic floor muscle. Like, every muscle group is just in such spasm that, if you remember back to Anatomy 101 in medical school, when a muscle's completely contracted, it can't contract any further, right?
Yes.
So they say squeeze, and these women can't squeeze. They're like, oh, you have no pelvic muscle tone. You need to go get Kegels. No. You got to get these muscles to relax, as you're well aware, which is why I send them to you, before they can even learn to recruit those muscles.
Yes, exactly. Yeah. I'm explaining a lot in clinic in the terms of, like, like you just said, we can't take something that is shortened and tightened up and be able to function that way. The muscle needs to be able to lengthen, it needs to be able to relax, and then it can do its work of contracting and being strong again. But I think we both agree, a lot of providers will miss the mark. And I would say we have a long way to go on the reliability and the validity of diagnosing that pelvic floor muscle tension.
Right.
Yeah.
I agree. I mean, for now, it's kind of things we've been taught. I mean, those that are, aware of it, it's kind of just based on muscle tension that you palpate directly. I tell patients, like, you should feel like your thenar eminence.
Yes.
And if
Oh, that's a good analogy.
yeah,
I like
yeah.
that one.
When you palpate those muscles, it should feel just like, you thin or eminence. But
Yes.
if you're able to pluck like guitar strings, those muscles are so tense they're in bands, and and then furthermore when you push on them if they're tender, that's kind of what we have. I mean, the way presently we kind of diagnose that, right?
Yes.
And so there's a lot of inner observer variability there,
Right.
as well as probably a big lack of training in that area of diagnosing it. I mean, they look at the tissue like, oh, prolapse, oh no, pap smear, done, you're good, out,
Right.
and they just kind of move them on because I think a lot of, again, I'm not minimizing generalists, but they just don't have the training to look for this or to know to look for this. And, I get the gamut of patients either, diagnosed with interstitial cystitis or diagnosed with, I mean, used to love the old one, female urethral syndrome, which is basically a crazy hysteric woman.
Right.
Or just a plethora of things that are just misdiagnosed, right? And it all comes back to
Yes.
the pelvic floor. And I think IC is the big one. Everybody's like, oh, you go frequently. Well, you can go frequently because you have pelvic floor dysfunction, right? And so I just think that's something I would like to raise more of awareness of, to look for or to think about in these varied presentations.
Totally. I mean, there's so many recurrent interstitial cystitis with pain, pelvic pain, that come in and they're like, it's been rounds of antibiotics. It's been, no true functional assessment has been done in many cases.
Right. And the reality is I probably spend most of my time talking patients down out of their diagnosis of IC because once they get it, they kind of hold on
Right.
to it like, this is my diagnosis, this is what I have, this is the reason for my problems. And I tell them, no, this isn't your problem. You don't have any symptoms that are consistent with the International Continence Society's
Right.
diagnose or what's the word?
Criteria.
Criteria, yeah, thanks. Criteria for interstitial cystitis. And I'm sorry that you got diagnosed with that, but that's not what you have, and you should be thankful because we have zero treatment options for that anyway.
Right.
Right? What you have, guess what? You have pelvic floor dysfunction. We can treat that.
Right.
You can do a 180 and have a normal life again.
I love that you're telling your patients that's very informative. It also kind of lends itself to the complicated territory that we're in, right? With pelvic floor dysfunction. So we can't really call something pelvic floor dysfunction without acknowledging that there's so many parts involved in it. It is the brain and the nervous system involved in it. It is the emotions involved in it. It is
Correct.
the muscle function involved in it. It's the gait pattern. It's the strength and the flexibility. So it's broken down into a really wide array of things. And I think that we struggle sometimes as providers to be able to, we all want to have that patient walk out of our clinic and be assured that we have a really good grasp of all those things going on in them. But I've also learned that in many cases, that patient needs to be in the care of a mental health professional too. Their daily life might look like depression, anxiety, inability to function at work, inability to maintain relationships and intimacy. So they have these big compounded issues, right? In the snowball cases. And I've loved the patients that I can be able to collaborate with mental health on their care. But we know that New Orleans has kind of a lack of mental health providers.
Yep.
In general, we don't have the numbers, and sometimes the ones that we have really long wait lists to try to get into. So what do you think about that part of the spectrum?
No, I completely agree. I find it very unfortunate that a large percentage of my patient population, again, working for the state, I see a fair amount of Medicaid patients. And there just aren't many outlets, either honestly, for pelvic floor physical therapy or for mental health, right? And then what I find is that even with many of my insured patients, access to mental health may not have the coverage that they think that they have. And, when they see the price point that they're, presented with, they're somewhat hesitant to engage, to go down that pathway, even though I encourage them, listen, cognitive behavioral therapy in this scenario is going to help you a lot, along with, as an adjunct to the pelvic floor issues, because again, this is multifactorial, right? And our access here isn't what it should be, or could be.
Yeah. And what other models could we rely on in other cities? Like, are you aware, I know with your Cleveland Clinic background and training, do you collaborate pretty often with your team up there that you had trained with, or?
I mean, from time to time, I will call to question to, get some input and feedback. But again, I felt like I was honestly in a bit of a bubble when I was training there compared to where I am now. People flew all over from all over the world to get treatment there. So money was never an option for any treatment modality. And then coming back here to the Deep South where, people are still struggling to eat, that we have, food poverty here in America is still crazy. But yeah, so patients are like, okay, am I going to use buy this medicine, or am I going to eat, or am I going to go to physical therapy or mental health provider, or am I going to eat? And so I felt like, yes, I mean, I loved training there. That was amazing. And the resources that we had at hand were amazing, but that's not my current reality. And, so I kind of have to adjust and within the system that I'm in now, and it's not just the system. It's honestly the region, the area of the country that we're in, and the poverty here is a lot more than what I experienced in fellowship. So no, I don't have the same resources, which is unfortunate.
Yeah, totally. And how would you see that evolving in a good way into the future of being able to handle those volume of cases that really need the interdisciplinary intervention and the mental health access, but can't afford it?
Wow, I don't know. Like, again, kind of on a daily basis, I just say, we have to try to do the best that we can, and again,
Per patient.
And there are some referral sources, but the reality is it's a wait list, right? They just get put on a wait list. And it may be 2 months, it may be 6 months, before they get seen. And that's really unfortunate, but that's the reality of the space in which we practice. It's not something that's presently prioritized, right? Because it's a quality of life issue. It's not life or death. It's quality of life. And so I feel that it's prioritized differently within the system which we practice. And, those that can't afford it, unfortunately, end up waiting an inordinate amount of time.
Yes. So this sparked something in my mind about our local field of OBG too.
Yep.
Because of Medicaid population, the inability to access what they need for resources. And like you said, making those decisions, like how can I decide on seeing more providers when I'm having a struggle, with my daily finances? So I've talked to a few different physicians that would love to be able to refer the patients that have less resources into like a large mind-body type of group, like yoga, for instance.
Okay, yeah.
Like yoga for pelvic floor, and offer it at like either low cost or sliding scale or no cost, somehow pull in some volunteers and begin to teach and train mind-body techniques to this population struggling with pain and complex issues, But, I don't want to say like, oh, just go to yoga, because that's not going to solve their problem. But it is going to teach them some tools that they can use at home. And maybe they'll engage with it in a way that they begin a daily practice with it.
Yeah, I totally agree. I have had several of my patients that have also utilized yoga along with their pelvic floor physical therapy to help in the muscle relaxation, or in the
Down
physical
regulation.
down regulation in the PT term. And, much like we were talking about the lack of access because of cost for therapists, psychologists, one of my good friends runs Nola Vibe Yoga. You can get sessions with her throughout every day of the week from about $5 to $10, which I don't think is out of the price point for most people.
Right.
Most of them are in outdoor locations. There's a few indoor venues they utilize as well. And that's would be a good outlet for a lot of our patients needing the intro into yoga to start the healing process.
Yes, I love that you just brought it down to the healing process, because it is a mind-body pathway.
Correct.
When they're taking a yoga class in a group where the intention is to slow down and breathe and focus on their body, and connect into their body, that is like a toolbox that's beginning to emerge and grow with their body and mind connection, with their body awareness, with their breath awareness. And when we start to tease out these functions in a chronic pain population, if they can just do breath exercise and body awareness exercise, that can have a huge positive impact on their outcomes with pain.
I agree. And let me ask you a question now. What are your thoughts or opinions about let's call it a controversial topic about actually carrying stress and pain in the pelvic floor?
I love this. So I have two mentors in this field. Lynn Schulte is a pelvic floor PT in Boulder, Colorado, and Tammy Lynn Kent is a pelvic floor PT who's written The Wild Feminine, which is an amazing resource for women living with female pelvic dysfunction, because she's a pelvic floor PT, Tammy is, but she's also this like energetic woman of, like indigenous informed cultural ancient wisdom to access. And so through both of their knowledge and training courses, I've been able to access a broader understanding of how we do carry stress and emotional tension in our bodies, and specifically the pelvic floor region. And so a long time ago, are you familiar with The Body Keeps the Score?
Yes.
Okay, so that started to really kind of wake up my mind in like, okay, there is a lot of trauma-based pain walking around. And when I was able to dissect it more and follow people who were really pelvic floor focused in that area, then I started to be able to see that in my patient population. It just blew up. Like, whenever you're expanding your awareness of a certain issue, and then that patient walks in the door and you're like, I see this totally differently. How did I not see it so clearly before?
Right.
And so the pelvic floor tension cycle is very tied in to our experience of stress.
Right.
And we don't have great empirical evidence for this. This is why it's controversial. It's why it's hard to sit at the table as like a scientifically minded, Western trained medical professional and talk about energy and emotions and the imbalance that happens in our health, in our systems, in our bodies, whenever stress is not regulated, or when we've had traumatic experiences in our past that are still not healed. And so with my female patients, I'll commonly say, like, we push that stress down into our pelvic floor, and it can stay there and it can snowball, like we were talking about before, in the physiological way. It can snowball in a way that a person may want to block it off, deny it, push it down more, not access it. And then we end up with kind of like a disconnect going on between their body tissues and their daily waking awareness.
You know, and again, I think in this area, that's doubling back to the yoga thing. I think this is where that can really be utilized in trying to reconnect with your body, really learning to let go of the bad energy, the bad stressors, and bring your mind body connection back into, you know, to your center, right? And
Yes.
I think that it's a step. Again, I'll use the word again in the recovery of pelvic floor function. Pelvic floor muscle dysfunction.
Yes, totally. And I think, okay, maybe this is just my lens being in the PT corner, that particular piece of the puzzle is overlooked sometimes, right? In like conventional pathways in medicine.
Very, very much so. Again, I think we touched on this earlier. I just find that we get so focused on palpable or tangible pathology that we kind of sometimes forget about the emotional side, right? Like I'm a surgeon, like I don't, you know, but in doing what I do, I kind of feel like I'm 50% psychologist or psychiatrist, you know, in talking with my patients, because there's as much of a psychological component as there is a physical pathology that's going on, right?
Right.
And so you have to address both if you're going to get them to a point of healing and wellness.
Yes.
And, you know, again, I'll just give you props because this is an area where I am able to diagnose, but inept to treat, right? Like I tell my patients, I know what's going on, but this is out of my wheelhouse. I can't treat this. And this is why I'm glad we have the great physical therapists we do have in the city. I wish we had more, and maybe one day we will, but I'm very, very fortunate that I can refer patients to good physical therapists to get this treatment and start them down the pathway of healing.
Totally. The power of touch. That's a big topic that we talk about a lot in our field. That, you know, there is something that we may never be able to quantify, that energetic power of touch.
Yeah.
Whenever I'm with a patient and they're on my table and I'm able to access their calming state physiologically, where their parasympathetic nervous system is like, oh, okay, I'm here.
Yeah.
I can breathe deeper. I can, you know, rest and digest. I'm always telling my students, like, just remember rest and digest. Like, when we are safe and our needs are met and we're not having to run from the tiger or provide food for the family on the table that night and we don't know where we're going to get it, when we're in a state of safety, then we can digest our food. We can relax our muscles. So I try to create in the clinic a feeling of safety and calm in the moment. And I want that patient more than anything to be able to access that, remember how that feels, and come back to that at home as a home practice. So we can walk down that path in very many different ways of breathing techniques and stretching strategies and body awareness and proprioceptive input, self-care in terms of internal myofascial release. We use a lot of the intimate rose pelvic wand to be able to do trigger point release with breath work. And it's a lot of information going on in a session.
Right.
Too much information overload sometimes is going to take away from that nervous system's ability to relax.
To relax, yeah.
Yeah.
And I try to do my best when I send patients to physical therapy to tell them, okay, this is going to involve internal work.
Right.
Okay. They're going to be getting up in there. Okay.
Right.
Like, like you're going to be wanded, you're going to be palpated, and they're going to teach you how to do that as well.
Right.
You know, and that's one of the unfortunate things I find also in this field is that I find it very unfortunate that so many women don't know what's down there.
I know.
And it's so funny. And this is I'm digressing, but I'm going to go ahead and do it. I started watching this really tacky HBO special called MILF Manor.
Okay.
And it's really egregious, but it's like mindless fodder, where these mothers are dating their sons, and there's a segment where the mothers are educating their sons on anatomy. And I find it really, really interesting that most of the moms didn't know some of the anatomy, nor did their sons. And I don't know, I just find it very reflective of the culture. And like, okay, you have this dysfunction, but you don't know what's down there. And I don't know, I just find like a big like education gap, like awareness gap, like
it's huge.
Like, it's part of your body.
Yes.
And like you ignore it, don't, or whatever, but it's your problem now because this is what we're talking about. Like, this is your problem, and you don't even know what's there, right? Like, do you see that, like, in the patients that come to you?
Many times. I have a pelvic floor model sitting on my desk that is always there. I mean, the pelvic floor model for me has become such a thing for me to hold on to while I'm talking to a patient in education, because I use it so often to be able to not only visualize the muscles and the anatomy, but also to just be like, this is our pelvic floor. We need to look at it more. We need to sit in the room with it more. We need to become friends with this pelvic floor, because we're at a state and time in 2023 where you're exactly right. There's many women walking around that do not know their anatomical parts.
No, not at all.
And that plays into that disconnect that is kind of like that soup of, okay, if pain is triggered, then we don't really have a body awareness going on, and our neurons are going to be, it's going to be a different map cognitively in the brain for the sensory part of the brain and the sensory motor connections that are coming in. So when we can more readily like enhance that anatomical education of the general population and get them comfortable with knowing their own body language, speaking about their body parts, being able to like own it, feel it. I love to encourage like mirror self-education at home. Just look at it. Like, we need women looking at their pussies.
Exactly. Or even be able to say that, or even say vagina.
Yeah, let's
like,
just say
most of them can't even say vagina, let alone pussy.
Yes. And in the deep South, growing up, like, my mother did not tell me the word vagina.
No. I have a patient that calls it her monkey.
Yes.
And I stopped her right there, and I said, ma'am, we're going to use adult language in this clinic. This is your vagina, and we'll refer to it as your vagina.
Thank you.
Because I will not refer to it as your monkey.
Yes, and this is rampant.
Yes, it is.
This is not
Deep
a
South.
one-off.
God bless.
Yes. So we need to start saying more, but I'm just going to start saying it more in the grocery store, actually.
Vagina.
Yeah, vagina.
Well, I challenged one of my fellows to embroider me a scrub cap that says the vagina is not dirty.
Nice.
Because that's the other thing I get into, like abdomen, vagina. They're like, oh, gotta change your gloves. I'm like, everything I'm putting in vagina is coming up through the abdomen or down from the abdomen into the vagina. Like, so
yeah.
Tell me, like,
same canal.
Yeah, leave me alone.
Right. And just like you were saying about the urethral dysfunction.
Yeah.
let's hit on that for a second. The
Okay, yeah.
hysteria.
Yeah, so like, back in the day, old school urologists used to have a term or diagnosis of female urethral dysfunction, which basically was just treating what they perceived as female hysteria, complaints that they didn't know what was going on. Well, let me rephrase that. It wasn't complaints they didn't know. It was complaints they didn't care about.
Yeah,
And
even worse.
it was the female patient that coming back and back to the office, and they're like, let's placate her. Oh, okay, this is how we'll do it. We'll dilate her urethra up to like a 32 French, and that will placate her, and she'll be better. And I first started practice here. I had many patients that would come to me from seeing older generalists and be like, I just need another dilation. And I was like, what? They're like, yeah. And then I'm good for a while. I was like, okay, the problem is not the problem. And I don't know what the treatment was or what you perceive the treatment being, but like, I will not do that. That's barbaric. Absolutely not. That's like, I'm not a Neanderthal. There's no way I'm dilating your urethra for no reason. But that was common practice in urology back in the day. And
explain to us the width of like the 32 French.
Oh,
and
32
the width
French.
Of the urethra.
Okay. So a standard catheter you would put in would be about 16 French. That's a standard catheter size.
That fits like the normal anatomy.
Correct. The female urethra easily accommodates that.
Yeah.
So take that and double it in diameter. And that is what was gradually, sequentially dilated up to, which is barbaric.
Yeah, it's almost mutilation in a way.
Yeah, in a way, but it was it was okay. It was okay because they were just good old boy urologists, and that's what they did.
Right.
I have a very different viewpoint, and thankfully, no currently practicing urologists that were trained, beyond the dark ages are doing that. But there's still a lot of dinosaurs that refuse to retire that are still doing that. But yeah.
Yeah, that's where the new has to start replacing the old framework.
But they had no clue what they were even doing. Like, they didn't even know why they were doing it. They had no clue that the vast majority of these females, the problem was the pelvic floor.
Yes.
I mean, you're a urologist. You should know the pelvis better. Everything exits through the pelvic floor musculature: the urethra, the vagina, the rectum. So when there's pelvic floor dysfunction, you get pathology in all of those end organs, right? So, but they never put two and two together because largely I don't think they cared.
And they didn't want to say vagina.
They didn't want to say vagina. Yeah. Yeah. That's probably fair.
We're going to do training lessons and let's say vagina to the medical world. The dinosaurs.
When I think about how many females have been treated over the years by urologists, it's really unfortunate that they really had a very, very poor perception of female function, sexual or otherwise, right? And gynecology, I think, as a whole, did a better job at that. But even when it comes down to this level of dysfunction, I think it's a bit more, I guess now I would say subspecialized, but they in their training, unless they were in a unique program, they just didn't get directed training in this area either.
Right.
Right? They're all about the vagina. They could say vagina. But this facet of the pelvic floor they overlooked. And again, I'll give you a great surgical example. The vast majority of generalists with a fourth degree laceration don't know how to reconnect the anal sphincter, right? They don't know how to identify the circular musculature and do a sphincteroplasty.
Right.
They whip stitch some shit to. Okay, we're gonna segment. They whip stitch some stuff together, and call it a day. And again, it's training. Like, I'm not hating on anyone. It's just a matter of training, and this level of pelvic floor dysfunction is kind of glazed over in a general residency because there's not time for it, right?
Right. And do you see that could change though? Like bringing in topics like sexuality. I really love like the sex ed part of our pelvic floor field that, it's kind of like you were speaking before about you're in a role of combining mental health strategies with your approach as a physician of being able to help that patient in the holistic framework. I feel like sex therapy is that field too that can integrate with us.
Oh, 100% agree. Again, in this market, the downside is there's such a paucity of providers within that space that it's almost impossible to get patients,
Yeah. And they're not in the insurance network.
triage to them, and
Yeah.
they're not in the insurance. So it's all cash, right? And again, I'm not in Cleveland. I don't have people flying over here from Saudi
Right.
to be treated, and so the cash flow is a big issue and a big impedance to that type of therapy.
Yes. And so, what if female sexual dysfunction became a hot topic, like in our capital city of Baton Rouge, in the lawmaking body, where they were like, oh, this is actually a huge issue?
Have you met our governor?
He does not say vagina.
No.
Yeah.
Female sexual dysfunction? No, that's never rolled off his
what's
lips.
that? Whatever. Mm-hmm.
No, actually, I like our governor. I'm not.
I know. We're not hating. But we do. I often look in the mirror at myself and say, I need to advocate more. I need to get the message out louder to people who are in places that can influence things like what's covered by insurance and what's not covered by insurance. How can we have better access to the care that people need whenever they're dealing with something so pivotal? Like you said, it's not life and death, but whenever they cannot enjoy sex, that is a huge part. I would say that it's one of the biggest quality of life issues.
Yeah, but convincing the insurance companies to do anything
To treat it as important.
on that line, okay, if you feel marginalized as a female, think about how much more men are given the attention in healthcare for male issues. And the fact now that none of the ED drugs are covered. Now, granted, they've all gone generic, but even when they were, like, there was the coverage, like, they just didn't prioritize that. So,
Right.
do you think they're going to, like, really give cares about female sexual dysfunction?
Right.
No.
By the way, the pharmacological treatment of vaginismus you went over.
Yeah.
And you talked about Botox in some severe
Yeah.
cases. Is there any pharmacological management of, like, a case where they can't have an orgasm or
Wow.
in the pleasure circuit?
So now you're hitting me at a level that I need to do more research in and get into more. And I've just recently started talking with my newest partner about going down this pathway because this is a very, very under-addressed area.
Are we going to talk about ketamine?
That we don't know. I mean, we don't have a lot of great research about, right? There were some drugs on the market that seemed promising that, once they got through phase 3 trials, they never made it to market. And so the majority of the space is still a lot of off-label treatments. And this is an area where we can do another podcast in the future to further it, like, double back on, and hopefully we'll have a better conversation.
Yeah, that's because I don't know what's out there in that part of our fields.
Yeah, I mean, honestly, there's most of it's off label, and
Okay.
and cash pay again, being off label,
Right.
and so, but there's still space for it. It's still something that's very under addressed, and we need to do a better job in this city about with addressing it, and we're gonna work on that.
Yeah, that's
Yeah,
great.
for sure.
That's something, well, whenever you were talking about drugs for erectile dysfunction
Yeah.
and that coverage and the change and that the shift, and that's like in male-centered care, then it just sparked that
Oh,
thought. Like,
the
wow, look at
billions of dollars that were made.
Yeah, right.
For an erection.
Right.
Yeah. To further cause more female pelvic muscle dysfunction. Yeah.
Yes. Yes, let's get to the.
Because she wants it 8 times. Yeah.
So wait, actually, so enlighten me on this, because are you saying that in a case where a male takes Viagra and then they just have like rounds and rounds of sex?
Yeah.
And then you would see that patient as like that was the triggering episode to their pain?
That could be, right?
Yeah.
Honestly, any inciting event. Like if it was good for a while and she said, okay, fine, one more time, and that time was unpleasurable, that could start that cascade that we were talking about, right? The pelvic organ crosstalk and everything kind of like tensing up and then never really recovering.
Right.
Because let's be honest, like if they don't have some lube, she ain't gonna be like that wet for that long.
Right.
Yeah.
Exactly. Like we went through 3 bottles of lube.
Yeah, no.
So, okay, with this, because you just touched on something that we've been coming back to, the disconnect. And that has a lot to do, like I'll pull on my Tammy Lynn Kent. I love her, the wild feminine. So that emotional side of the pain experience during intercourse, and how a lot of females we'll talk about this in like girls circles. This is not just clinic talk. This is like, oh, it was kind of hurting, but I just kept going.
Yeah.
So there's kind of a sentiment of like, why would I say anything or stop him from having an orgasm, or her, right? Like,
Yeah.
let's just open it up. And I'm not going to say anything about my pain because I either feel ashamed about it, or I'm embarrassed, or I don't want to affect my partner's pleasure. So then there becomes like that again. It's a kind of a foundation for that snowball to begin to cascade.
For sure.
There's huge emotional components of that.
Absolutely. I mean, I've never talked about this in girls circles, but I believe you.
Yeah, right. Like just kind of, what is the old kind of saying about it? Like just shut up and grin and bear it.
Yeah.
Like act like you're having fun.
Yeah.
So this is we're touching on a societal and a gender issue in a way there, I feel like.
Occupy your role.
Yeah, right. Or the subservient, oh, my purpose is to, and I feel like this was my mother's generation more than ours, for sure.
Yeah, I think there's a lot more liberation now, but there's definitely a carryover.
Yeah, there's a carryover. We were ingrained with that as children. So then, or, taught to feel that masturbation was like a bad thing.
Therefore, they don't know anything what's down there.
Right,
Sure.
exactly. And that sex is something that is like obligatory.
Mm-hmm.
And so I have to, in some patient cases that are like very conservative, we're talking about, my Baptist North Louisiana upbringing in the Bible Belt.
Mm-hmm.
Don't talk about sex when you're little. Don't even act like you're going to masturbate. What is masturbation?
God bless Jerry Falwell.
So in this type of patient case that I can identify with, because that was kind of my background that I had to evolve from and grow through, then I'm like, okay, wait, number one, we have to come to this belief that like your pleasure is important. Your pleasure is a part of your body. It's a part of something that you have a right to experience. And your pleasure involves the brain and the body in these very intricate ways. So we want to be able to, again, get that comfort level and remove the stigma and be able to say vagina and pussy and all the words and be able to embrace all the parts. And that can be a very long process for someone who's been ingrained in their culture.
Sure. Absolutely.
What helps with that other than coming down to Mardi Gras in New Orleans and being liberated?
Wow. I mean, again, that's a deep question for a surgeon. I don't know that I can tell you. I don't know that I know.
We just
I think of a lot of, again, I think a lot of it is just exposure and getting out of your comfort zone and opening your mind a little bit and realizing that not everyone thinks like you think and understanding how other people think. Again, if I can digress to a TV show, right? So the last episode of And Just Like That, the Sex and the City reboot, whatever. So Miranda has decided she's either a lesbian or bisexual. She hasn't completely given us all the details, but she is in a relationship with someone who defines himself as non-binary. And comes to find out that her love interest has basically a sham marriage or a scam marriage for whatever reasons. And they all end up in bed one night. And he kind of they're getting it on, and he kind of wakes up and puts his arm around her love interest. And she sits up and she says, I don't know if I'm okay with this because it's something new and I haven't thought about it, or if I'm opposed to it. And she thinks just a few more seconds and she realizes it's because it's something new and she hasn't thought about it, but she's not entirely against it.
Right.
So she opened herself up to something, and again, please, to the listeners, I am not promoting thruples, okay? But she opened her mind to something different.
Yes.
And again, we're not talking anything on that level, but what I'm saying is that sometimes you just have to think that people may think differently, and that's okay. And that's how you can get out of that mold, right?
Yes.
You can learn to pleasure yourself. You can learn to understand what your vagina is, what your vagina entails, what all is in there, like how different areas feel, what the different muscle groups are, which is all of which physical therapy involves, is like targeting different muscle groups. When patients tell me like, oh, I'm going to do Kegels, and like, no. You're not going to be able to do them without direction. And that's what I find in the vast majority of my practice. Most of my patients, female patients, can't do Kegels without directed guidance.
Yes.
Guys, sure. Like, we all know how to stop our stream. We've done it a million times. That's easy. Most of my female patients cannot target muscle groups without direction.
Yes.
And that's where, again, physical therapy becomes such a vital component in the treatment process.
Totally. I love that you led us down to that, because I feel like in our language of how we would use cues to be able to guide a patient to recruit their pelvic floor is really important. In the beginning of my pelvic floor pathway, I would use a cue that was you're going to squeeze your pelvic floor area like you're trying to hold in a fart. And it's a perfect cue. Well, it used to be a perfect cue in a way. I liked it in the beginning because it's a universal thing. Like, we've all been in a situation where we need to fart and we're going to hold it in. So it has like a dual meaning behind it though, because the patient is always going to laugh at that. It's always going to laugh. It's always going to relax them one more notch. And they're like, oh yeah, I can do that. And it's like the recognition happens and they connected.
And they get it?
Yeah, they get it.
Can you work on my partner with that?
Totally. Totally. I'd love to. It's like the light bulb will go off because all of a sudden their brain and their pelvic floor muscles connected and they felt it. And so then they may have a terrible coordination though, and that's when I'm internally assessing and palpating, like what is really the levator ani able to do at this point. If I've assessed it, like we were talking about palpation skills.
Yeah.
If I've already felt, that guitar string of tension where there's high tone and I know that that's foundational, then I still want them to try to practice holding in a fart because I want to see what happens after they've tried that contraction.
Okay.
And after they've tried that contraction and a breath or 2 or 3 breaths where I can feel like, what is moving here at all? And are they able to get any proprioceptive input at all just from my finger palpating? The holding in a fart is universal male and female pelvic cue, I feel like. But there's been a lot of exploration I've done in language of being able to visualize their pelvic floor better. So I will say sometimes like, okay, imagine your pelvic floor as a trampoline. And you are a little girl jumping on that trampoline. And I want them to be able to imagine that trampoline bouncing down and lengthening.
Yes.
And then rebounding up with all the power and strength and boom, you're up in the air.
That's a great analogy.
And it works so well. And it's an emotional and cognitive connection. They're thinking about themselves as this joyous little girl on a trampoline. They're being able to tap into the morphology of their pelvic floor, how it expands and lengthens when it's relaxed, and how it contracts when we need it to go into strength phase. And they're able to kind of use that visual landscape in their mind. So I love playing with metaphors, visual language, different cues that I can see whether it's resonating with that particular person or not, based on their whole history and their selves.
No, that's awesome.
So that's a really fun thing to do in terms of discussing it, talking about it, bringing light to it, seeing it in different ways. But I do want to mention the power of sitting in a circle of women who are either dealing with incontinence or dyspareunia or whatever it is that is limiting their quality of life, when they're talking to each other about it openly and in a safe space, and they feel heard and they feel like, oh, she's going through this experience too. What helped you? Well, I found this. And it's such a growth and connective experience that it does start to release those barriers of shame, stigma, and they're learning.
Very powerful.
I want to start a women's circle with pelvic floor PT talk, a nutritionist coming in to talk about what we're putting in our bodies, and a mental health professional to talk about positive psychology approach. And I think, that's like
great.
Interdisciplinary. Let's talk about sex. Let's talk about pain.
For sure.
Because we need those variables in there.
Absolutely.
And then we need to get to the level where we can make that like a free group, right? Like come to we want to call it pep in your step.
Pep in your step.
Because the P is pelvic floor, the E is eating mindfully, and the P is positive psychology.
Nice. Pep.
Yeah, get a little pep in your step.
Nice. I like it.
So if we could do that on a mass level.
That'd be great.
Right?
Yeah.
Women's education.
There you go.
Okay. So I've had so much fun in this conversation. Thank you,
great.
Dr.
It's been
Ryan.
great.
I want to end on this question. So we've talked a lot about the conservative approaches.
Right.
And we hit on a little bit, which I do want to delve into further in another podcast, with the surgical and pharmaceutical approaches.
Sure.
But I want an example, if you can think of a case that had a really excellent outcome with a conservative approach.
Okay. Yeah. So there was one day at the gym, one of my gym mates came up and tapped me on the shoulder. He's like, I know what you do. And, we've all been in this gym for a while. He's like, can you see my wife? He's like, we can't have sex. He's like, it's just shut down, can't happen. And I was like, absolutely, I'd be happy to. And immediately I was thinking, okay. And this was like when I was doing CrossFit, and I was like, I almost already know what's going on even before I saw her.
Right.
And so she came to see me, and just like we discussed, completely upregulated pelvic floor musculature, every muscle group, exquisitely tender, levators, piriformis. Well, I mean, listen, my fingers aren't long enough to palpate the piriformis. Obturators.
Yes. We hate those obturators when they get angry.
Exquisitely tender.
Yeah.
And like not quite to the point, even in the introital muscles, like not quite to vaginismus, but like just shy of it.
Right.
And I was like, girl, I know exactly what's going on with you. And so I started on some suppositories, sent her to a physical therapist, which is what I do most of the time when I see this. And then it's like months, because again, what you guys do is months of work.
Yeah,
right?
It takes time.
So I kind of forget. I don't think about it anymore because I'm great at disassociation. So I see him at the gym. I see.
Yes.
I'm like, I don't think anything of it. It's months later. He comes back, taps me on the shoulder again, and he's like, "Thank you, man." He's like, "It's like normal again." He's like, "Sex is great. Everything's good." And I was like, "Yeah, you just have to like identify the problem." And
yes.
And this is where I find that physical therapists are miracle workers, especially pelvic floor physical therapists, because this is so underdiagnosed, and I'll even go further and say misdiagnosed.
Yes.
And they're setting down every avenue other than what they need. And once it's identified and they get directed therapy, they do a 180 and they're golden again.
Yes.
With the caveat that it's going to require some maintenance.
Right.
Periodic maintenance. But that's probably one of the sad man, elated man, right?
Yes.
And again, I'm not focusing on the man. The beauty of the scenario was the change in the female, in the woman, right? Like she
totally
was so much better. Her life was better. I just interacted more directly with her, with the husband. But
yes, you changed their lives.
And you guys did. I diagnosed. You guys were the therapists, and so this is why I feel like we can't do enough to raise awareness on this condition.
Right.
And the utility of pelvic floor physical therapy for this type of pelvic floor muscle dysfunction. Yeah.
Yeah, totally. And I would love to have you back to delve a little deeper
I'll let you.
into
Let's talk about stress incontinence. Let's talk about prolapse.
All the juicy
Let's talk about
stuff.
other pelvic floor disorders. A
lot
lot goes wrong down there.
How do we not even say the word prolapse in this entire
I don't know.
podcast?
Even if I should have taken that apple, I guess. I don't know.
So next time, tune in for some more juicy topics.
There you go. And then we'll talk about sex more.
Yeah.
Yeah.
We're going to say vagina.
Vagina.
50 times.
This has been fun. I thank you so much for inviting me.
Thank you. We loved having you. Thank you, Dr. Ryan.